Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Hello, everybody. Welcome back to the episode. This is a very exciting episode. Today, I'm joined by Vanessa Smith. She's a PA out of the South Dakota area. She's the CEO and founder of her website, orthorefresh.com. This website is a great resource for all providers, including all APPs, PAs, ATCs. It helps to decipher the upper extremity regarding acute and chronic injuries and has a great section regarding splinting with PDFs that can go over different splinting techniques so you can perfect these and be able to treat the patients appropriately. Vanessa, please tell us a little bit about why you started the website orthorefresh.com.
Yeah, I just seen a need for more education. I'm sure you have too, regarding orthopedics specific to the hand and wrist for our first encounter providers, for the PAs and practitioners and physicians that work in acute care and occupational medicine and family medicine and ER.
I think it's a great resource and would highly recommend people go to check out the website. Working in the orthopedic urgent care kind of perspective, I see a lot of hand and wrist injuries. It's one of the more common things that we see. And when I have students working with me, we often discuss, do I have to do special tests on everything? And this is one of the big things I try to get across to students is that not all acute injuries require a special test because you can get false negatives and false positives from these. So what are your thoughts on this? You know, when somebody comes in with an acute hand or wrist complaint, do you always do all the special tests, or do you kind of have a variation of how you progress with things?
In your mind, there's got to be kind of two separate things. If this is a trauma or injury,
Correct.
X-rays, and you see a fracture on first glance, you see a fracture, you don't do special tests. You want to know what's working and what's not. Like that's those are the questions I come back to. And then if it's a phalanx or metacarpal fracture, we look at the X-rays and the clinical exam to determine our treatment. But if it's a carpal fracture or radius fracture, we just look at the X-rays. So start to break down. You don't have a big exam for a radius fracture, but for phalanx and metacarpal, you have to look at the hand both with fingers extended and gently flexed to look for rotation. But yeah, just trying to map out a little bit to help them. Like, if you don't see a fracture, okay, you can start looking, but your trauma, what's working, what's not. That's the first kind of ways I tried to help them simplify it, because it can get overwhelming. There's just so much.
Correct. And I agree 100%. And I see that all the time, even from an, urgent care perspective. And when I have students with me, I mean, if somebody walks in and they immediately injure their arm and they can't move their arm at all, and they have a clavicle fracture, why are you doing a drop arm test on them?
Right.
And of course, the drop arm test is going to be positive. It hurts. I had a patient in clinic yesterday who went to see their primary care and went to an urgent care, and both of them documented positive Finkelstein's test. And so they came into me for a first dorsal compartment, like Dequervain's injection. Yeah. And I pushed on the first dorsal compartment. They said, no, it doesn't hurt at all. But I pushed on their CMC joint and they said, yeah, that's where it hurts. And I'm like, well, of course Finkelstein's positive because it hurts to move your thumb. But it's those kind of things where it's like, yeah. So let's jump into, what we were talking about. So, from your perspective, you'd mentioned that, in your area, and I think in my area as well, it's hockey, basketball, volleyball, baseball. I see some, field hockey or lacrosse type injuries. And I think one of the common things that I see and that you probably see as well is these PIP joint sprains, volar plate injuries. What do you often see from a treatment perspective when you get those referred from the primary care, urgent care, as far as what you teach, how to splint, when to buddy tape, how many of those require surgery, indications for surgery?
Yeah, so I'd start with every jammed finger needs an X-ray. Mm-hmm. Every jammed finger. You can't tell what's going on underneath, or in other words, we don't have X-ray vision. So to look at a finger just with our eyes, we can't tell what's going on underneath. You may have something simple like a volar plate injury or nothing at all, just a sprain of the collateral ligaments and capsule, or you might have a fractured dislocation of the PIP joint. So
Yep.
super important to get dedicated finger films for a finger injury. Don't get 3 views of the hand. We want, if it's the right index finger, get 3 views of the right index finger to include a true lateral. A true lateral is going to show the condyles or the proximal phalanx lined up. They superimpose over each other. Then you can really see what's going on at the joint. So if you get a lateral x-ray back and you see these 2 condyles, you can see both of them, then that you need to send them back to x-ray to get a better lateral. So that'd be the first couple of things is we got to get x-rays. We got to get dedicated finger films. If on the x-ray, usually on the lateral is where you're going to see that volar plate injury. It's a little small, seemingly nothing fracture of the volar rim of the base of the middle phalanx. That is technically a fracture, but we treat it like a sprain. So you could give them a splint, which they wear for sports, but otherwise they should be in buddy loops. Please do not put somebody in an aluminum foam splint and say, if this isn't better in 6 weeks, call hand. Under no circumstances, except for mallet fingers, should you put a finger in a splint for 6 weeks. No circumstance. Yeah. So especially this PIP joint, a splint for activities, maybe for sleeping. Otherwise, they're in buddy loops. Not buddy loops or buddy taping so that it stays still with its buddy finger, its neighboring finger, but so that they move together. So those would probably be the main points with that. The other thing is underneath those swollen fingers could actually be a phalanx fracture. And you don't know until you get the x-ray. The other piece of that then is looking at finger cascade. So I have everybody put their hands on the table or kind of set them on their lap in front of them, palms up, and just let the fingers chill, just relaxing. Can you appreciate how the index finger points straight down? The middle finger starts to turn a little. And then maybe your ring finger's parallel or it turns a little more. And then your pinky turns even more. They're all pointing to the same spot, the distal pole of scaphoid. So when you look at the uninjured hand, always have the patient do this with their uninjured hand first, that they're assessing their finger cascade, then do the injured side. If their fingers don't line up similar to the contralateral side, then we're concerned for rotational deformity, meaning the fracture has rotated and that would need surgery. So those fingers can be tricky. It's important to get x-rays.
Yeah, and I think those, from a surgical standpoint, rotational standpoint, you're talking more phalangeal fractures or metacarpal fractures, right? That wouldn't be for necessarily these volar plate injuries or these more soft tissue ligamentous injuries.
Correct. Yep. The other piece of that volar plate is looking at the x-rays when you get them, because I have seen people think that it's a volar plate, and do nothing for it, but instead it's actually an avulsion of FDP tendon off the distal phalanx. And that flex line is a piece of that distal phalanx way down by the PIP joint. So the other piece of this evaluation is the dedicated finger films, finger cascade, but then also is FDS intact and is FDP intact. They won't have full motion, but are they working? So in order to do that, we isolate that finger by putting all the other fingers. It's hard to talk about, but
it's easier to show.
Yeah, you're going to test, I have a video about it, but you're going to test both FDS and FDP to the injured finger. And if they're intact, and you see that fracture at the PIP joint, it's likely just the volar plate that's fractured. Yes.
Yeah, and I think that's a big one. And I've seen that before in the past where it's been an FDP avulsion, and it's definitely hard to pick up. And I know that it's always important to test, DIP and PIP motion. But as you said, I think with the acute injury, oftentimes they won't have full motion, but they'll have activity within that area, which will show you that it's intact. As far as the splinting that you do for sports, is there a specific one that you recommend for that?
For the finger?
Like if it was a jam finger or volar plate injury. I mean, the question we always get is an athlete kind of playing basketball, they injured their finger, PIP joint significantly swollen. They maybe have a fleck on the x-ray, but maybe not. Maybe it's just a soft tissue injury. And, the first question any athlete ever asks you is, when can I go back and play? And you had mentioned splinting for sports. What specifically do you do for that?
We lean heavily on our
OTs.
Or OTs, yeah, hand therapists to
Mm-hmm.
custom make. Usually, I just find hand-based splints stay on better than finger splints.
Yeah.
Uh, so if I or a long finger PIP or ring finger PIP injury, volar plate injury, it would be a hand-based ulnar gutter splint to include that finger with its neighboring fingers ulnarly. So ring and small, that sort of thing.
Yeah, and the other thing that at least our hand surgeons definitely always try to discuss and get across is that, a lot of the times if you're seeing a patient in the primary care clinic or the urgent care clinic and they do have this fracture that's documented on the x-rays, a lot of providers don't feel comfortable necessarily just discharging them without a splint on. And if you do put an alumiform splint on, I think you may or may not agree, put that in flexion so they're not losing motion, because oftentimes they'll lose, a motion of that PAP joint, which is why, as you had mentioned, don't splint it in extension for 6 weeks. So we always advocate 30 degrees of flexion on that alumifoam splint until they can follow up with us, and then we'll transition them to the OT hand-based splints and or just the buddy taping, depending on the exam and the fracture pattern.
Sure. Yeah, I haven't necessarily been that specific with splinting. Usually, if they get to me in a week or two and they're kids, they're not going to be stiff in that PIP joint. But definitely, if there's a dislocation involved, extension, splinting a finger in extension is not a stable position. So if
Mhm.
there's been a reduction of a joint, then it should be splinted in at least 30 degrees of flexion, if not more, to maintain the reduction. So that's a key time that we need to be splinting in flexion for sure.
And does it matter for you from that reduction and dislocation standpoint, dorsal versus palmar splint?
Not necessarily. I've got we commonly will do dorsal
Mhm.
blocking splint so that
Yeah.
in the splint with the finger flex, they could undo the tape and bend it. So bend it even further into the palm, but they wouldn't go into major extension. And then just in our hand surgery clinic, then we would slowly let them extend more and more over the weeks as the weeks go. But allowing them to take the splint down, but while in the confines of the splint, work on finger flexion. So we're kind of getting in the weeds a little bit, but um, finger flexion is a stable position after a dislocation, not extension. Yeah.
Yeah. And yeah, so I think, yeah, exactly. As you said, allow them to flex, allow them to move, don't create a stiff finger. I think oftentimes we're taught splint and immobilize for 4 to 6 weeks with any finger injury. And the new thought process, and it's not even new, is motion. Early motion is important to maintain that range of motion of the joint, which is,
Right. And we really face more stiffness with adults, right? Like
yeah,
kids don't get stiff. Kids
yeah.
don't get stiff. So, um, but definitely with adults. The other conversation we have with kids who are in sports and have an acute finger or hand injury is, are you getting paid more than I think you are? Then you're not playing, right? Like it's okay to take some time off to let this finger heal, because the concept too is if your hand isn't working right, then you're using your other parts of your body wrong, and you could do something to your back, or you could roll your ankle because you couldn't catch the ball, or and so even just holding on participation, I think we lean a little more conservative and saying, sorry, you're not playing right now. You can still go be with the team. You can still run, you can still do sit-ups, but you're not doing ball handling or tackling or things like that.
Yeah, and I think it's always important to give those athletes at least some activity level that they can do. Yeah, I understand that your finger's injured and you can't do this particular aspect of the sport, but you can still maintain conditioning. As you said, you can still be part of the team. You can still learn the plays and do the activities. Getting into that pediatric component of these PIP joints, which is something I often see, a kid comes in with a swollen finger and their x-rays are negative, but they still have growth plates in that areas. How do you approach that and educate, regarding that if it's a Physeal 1, Saltair 1 type injury, as far as mobilization and treatment?
Yeah, I think we still will do immobilization for comfort. So that'll be an option for the parents too, that, hey, they go to school in this, they can sleep in it, but they can take it off to shower and bathe, and they can take it off to eat their supper. If the x-rays are normal, pain will be their guide. And that goes
Mhm.
for adults too. We don't do things if it hurts. And so the kid won't use that hand if it hurts and the splint happens to be off. So I have a kid coming tomorrow. X-rays are normal. Finger got jammed in a car door, but we'll see what it looks like. And if they're still pretty tender and swollen, then we'll probably offer a splint versus even just buddy loops to protect, talking about how that protects the finger. But the kid tomorrow is 4 years old. So now as I think about it, I don't think those buddy loops will stay on. So I'll
Yeah.
probably give a little splint or something.
Yeah, and I think kids are pretty resilient with a lot of things, and they want to and/or will work through a lot of things. And so, if a kid comes in and they're favoring it significantly, I tend to immobilize a little bit longer and/or just give them a splint, but early follow up within 5 to 7 days to hopefully transition out and start motion. But if they're coming in moving it quite a bit, and their X-rays are negative, then as you said, you can kind of just buddy loop and start the early motion. So it has
Yeah.
to be an individualized basis, I think, per each kid. And some kids can't communicate if they're young kids, 2 years old, and they can't necessarily communicate where their pain's at. Those are always more difficult ones.
And reading the parents too. What are their expectations and trying to give them what they want, right? Because it's about patient
Yeah.
satisfaction too.
And then from a phalanx fracture and or a metacarpal fracture, as you had mentioned, I've always been taught the key points are look for rotational deformity on that flexion cascade, look for angular changes. I like to, as you said, have them put their hands on their laps, resting position to see if the profile of that nail is rotated one way or the other.
Yep.
Because that's the first thing, when I'm texting my hand surgeons, a fracture, the first thing they say is there any rotational or angular deformity? Like, what's the clinical exam? That's the first question they always ask. And so I think it's an important thing for, all the providers to know.
Yes, absolutely. Yep.
You had mentioned gamekeeper's thumb as regarding UCL injuries. How do you treat these?
Well, acutely, they're going to be guarding, right? They're going to have, because of the pain and swelling, they're not going to let you do a full exam of the ulnar collateral ligament. So acutely, you have high suspicion for gamekeeper's thumb, which is an ulnar collateral ligament tear at the thumb MCP joint. If they have fallen on or while they're holding a ski pole, or they fell and they remember their thumb went the opposite direction and they usually point toward their forearm. My thumb went way over here. Those would be concerns that we've got a UCL injury. The other way I initially look at it too is, and though you might not tell right away with all the swelling, is if you rest your hand on the table with the ulnar aspect of your hand, your fifth metacarpal resting on the table, and your thumbs are kind of just resting. They rest in neutral. They rest kind of in alignment with your first metacarpal and your radius. But if there is an ulnar collateral ligament injury, that thumb will be radially deviated and it won't rest in neutral. So just natural position of the thumb at rest is one thing to look for. And then swelling, tenderness about the ulnar collateral ligament. Try to do a little stress test, just like you would do a varus or valgus of the knee, stressing the radial and ulnar collateral ligaments of the thumb MCP joint. You're looking for pain and laxity. But initially, you probably aren't going to be able to tell much with laxity because they're going to be in so much pain. So do your best, document what you found, and then a splint as far as a probably recommended a non-removable fiberglass splint. So like a forearm-based thumb spica splint that supports the thumb to the tip. They don't take it off to shower until they are evaluated again. And I've known some hand surgeons to provide a little local anesthesia and stress that ulnar collateral ligament. Some will just do it without that and see what their clinical exam is. And then usually it ends up with an MRI anyway. But initially, it would be a thumb spike splint to stabilize it and elevate. Keep that hand at the level of heart or higher as much as possible. So when they're up and walking around, this hand is across their chest. It's not by their stomach and it's not down by their thigh. It's up across their chest. And that will help with pain and swelling too.
Yeah, and I mean we're mid ski season here, so we're seeing a lot of these so-called skier thumbs, ski pole type injuries. And then, as we talked about, I had a lacrosse kid come in the other day with a UCL injury, and so the big thing is immobilize, thumb spica splint. And you said follow up. What's your recommendations as far as follow up there?
Should be probably 5 to 7 days with a hand surgeon.
Mm-hmm.
Yep.
And do you recommend if they're in the primary care clinic or urgent care clinic to order the MRI, or hold off and let them see the hand doc first? Because getting the MRI early, is that going to change the treatment plan and or your guys' algorithm as far as surgical and non-surgical?
I in our area, in our practice, tend to not want primary care to order an MRI just because we might be able to determine what's needed without it, which would save $5,000, $6,000, $7,000, how much ever they are, and by just based on our clinical exam. And also, we've found that some outlying kind of primary care MRIs don't have the best quality. So then we've spent all that money, and it doesn't give us the minute detail that we need when we're looking for a stentor lesion at the ulnar collateral ligament. Yeah, so don't need to get an MRI. Definitely X-rays and splint would be the initial recommendation.
Yeah, and I think that's a big one. I get that a lot where there's some, companies in town, especially where we live, where they offer less expensive MRIs, but sometimes, unfortunately, the image quality is not quite as good, whether it's because of their software or the thickness of their cuts. And so they may miss some of those subtle things and then see you, and then you're going to have to send them back for a different MRI that has a more appropriate protocol. And that's just going to cost them more money, which is unfortunate for the patient.
Yeah. Yep.
And then you'd mentioned just a quick down and dirty as far as seeing somebody in an outpatient clinic from a distal radius fracture standpoint. Look at the x-rays. I always think is important. Splinting is important. Do you have a preference as far as splinting? Just, a lot of those Alumafoam or, splints I see from the urgent care perspective, or do you prefer the fiberglass kind of orthoglass type splints?
Yeah. If you're looking at the x-rays, so first of all, when you get x-rays, please look at them, right? Even though the radiology report isn't back, just super important to look at them and start to get repetition. The more you look at, the more you're going to realize what normal is. And then you're going to realize, wait, that's not normal. Unfortunately, we see a lot of people, x-rays are ordered, then they are discharged and they're told, we'll call you with the results.
Yeah.
Then they're out and about waiting to hear back. Maybe the clinic closes and they never hear back. So they go to their chiropractor only later to find out that they have a wrist fracture. So best practice would be, if you order x-rays, you look at them and you look for a fracture of the radius. You're looking at the Galula's lines. You're looking at the scaphoid. That can be a place, right? We're kind of letting our eyes pan up. And as you build repetition, you build a system of how you look at hand and wrist x-rays. And so I work proximal to distal with the wrist usually, as far as letting my eyes look at them. So if I see the fracture, I'm looking at specific measurements, which it's hard to describe without visuals. But if I see the crack, but everything seems to be lined up, then I would say a non-displaced fracture. And a wrist cock-up brace from Home Medical off the shelf would be just fine. If they are in a ton of pain and they have a ton of swelling and there's a non-displaced distal radius fracture, then I would put them in a non-removable fiberglass splint. So like a volar splint, or also called short arm splint, to give support. I have seen so many people have improved pain within the time from they step into the clinic to after I put the splint on, because now that fracture is supported and that helps with pain. So when we talk about multimodal pain management, a proper splint is part of that. Yeah. And so as far as like, if you start to see more comminution or dorsal angulation or loss of radial height, so it's now ulnar positive, then we would, or if you performed a reduction, then we would do something more like a sugar tong splint, where we're going from the palm, distal palmar crease, around the elbow posteriorly to the dorsal hand, but allowing for MCP joint motion. So that would be a more robust splint that doesn't allow for flexion extension or supination and pronation, but not every distal radius fracture needs a sugar tong. So would be my tips probably.
Yeah, and I would agree with you 100%. I feel like that happens so often where I see patients back and, somebody hasn't looked at the x-rays, and or sometimes, unfortunately, even the radiologist miss things. They don't have the benefit of the physical exam of us going in there and pushing on the patient and maybe seeing that subtle radial styloid fracture that, we go in and that's where they're palpably tender at, and we kind of take a more in-depth look at the x-ray. And so I tend to never trust x-rays, and I never trust x-ray reads because I've seen a lot of missed fractures because of that. So I try to teach the same thing. Even if you don't feel comfortable reading the x-rays, you have the benefit of the clinical exam, and you can go look at that and see if there's any subtle changes that you may treat more conservatively.
Right. Yep. Absolutely.
And I mean, I think with the wrist, maybe slightly different than the hand. Again, you can give me your expert opinion. I would more lean towards immobilization than not immobilizing, if that makes any sense. If somebody comes in and they're kind of extremely painful, and you take a quick look at the X-rays and they look relatively normal to you, but they're in a lot of pain, I don't think the answer is don't put them in a splint or a brace. The answer is, as you said, from a pain control standpoint, they could probably tolerate 5 to 7 days in some type of brace or splint just to calm the soft tissue down and then follow up.
Yes. Yep. Absolutely. Yep. Whether it's like we talked about, removable wrist cock-up brace or Modabber brace from Home Medical off the shelf versus one that you put on with cast padding, the fiberglass one-step splint, and the ACE bandage. Uh, yeah, either of those.
Yeah. I think a lot of patients, as you said, will come in and the provider will take a quick look at the x-ray and it will look negative, and they'll just kind of send them out with an ACE bandage and say, we'll call you if the radiologist read changes. And then they come and see me saying they got a phone call and the radiologist says there was a fracture. And,
Yes.
I end up then immobilizing them. So I think the wrist doesn't tend to get as stiff, and I better safe than sorry to immobilize those. Patients tend to do a lot better.
Yep, I would agree.
And I know you got to go, but one last quick, you know, scaphoid fractures and snuff box tenderness is always drilled into our head as like a huge and major thing. But I think people that come in with acute wrist injuries and radial styloid type injuries, they tend to have tenderness within this area. Do you have any teaching points, regarding this? Because I get a lot of patients sent to me with scaphoid tenderness, rule out navicular fracture, and by the time they get to me after some immobilization, their tenderness is no longer in that area.
Sure. Yeah. Nope. It's understanding where the anatomy is under the skin. So in an acute injury, we had a gal come today. She's maybe 5 days out now, so it's not right fresh. But she was not tender over the radial styloid. Okay. And then I go dorsal from there. She was exquisitely tender over Lister's tubercle, like jumped out of her chair. So like, okay, and that's it there. But I go back just medical legally, any foosh, any fall and outstretched hand, I always palpate the snuff box. Just so I say no snuff box tenderness, so that whoever reads this someday knows that I did look for this. And that is to put my thumb in the snuff box, and then I try to have them relax, and I take their hand and I ulnarly deviate. So I passively ulnarly deviate the wrist, and that will make the scaphoid thump, thump, kind of thump into the snuff box. You'll feel it kind of come up to hit your thumb. So that's one thing, is to passively ulnarly deviate the wrist with your thumb in the snuff box, and you'll be able to feel that scaphoid, and you'll ask if this is causing pain. If they don't jump out of their chair, it's not fractured. The other way
Uh,
to get to the scaphoid is volarly. You trace the first metacarpal or thumb metacarpal to the base, so the CMC joint, then go proximally. The next hard bump that you feel is the distal pole of scaphoid. So by pushing on that, you kind of are rocking the scaphoid. And if that is painful, that would make you think that the scaphoid is injured.
Awesome. I just
Does that
learned.
make sense? It's
Yeah, I
hard
just
to
learned.
describe without showing you. But
No, I just learned too many great things. And as you're doing that, I'm sitting there trying to push on my own hand, trying to see if I can feel those changes. So, no, I think that's great. And I think you would maybe agree, people that are acutely painful, maybe you'll get a false positive of those tests just because of the acute injury. Do you think that exam that you just described would be the same if they're day 1 versus day 7, or does it change for that
I
particular
mean,
injury?
it might not be tender later, and that's the whole point of the follow-up, right?
Yeah.
Your first evaluation is mostly a triage. Does this need to go to surgery now, or does this need to calm down a little bit? Let the swelling calm down, let's get the pain under control and have it reevaluated. So, just documenting what you find. Um, I have seen trans-scaphoid fracture, it's radial styloid, trans-scaphoid fracture, perilunate dislocation,
Yeah.
right? So like there is a radial styloid fracture, there is a scaphoid fracture, but also the lunate is sitting out volarly in the carpal tunnel, and
Well,
all of the intercarpal ligaments have been disrupted. So you're going to see that on X-ray, but that's the only time I've really seen major, like exquisite pain at the radius and exquisite pain at scaphoid.
Yeah, and I think, from a hand perspective and just from an orthopedic perspective in general, I always try to teach like trust your palpation, use your palpation skills, know your anatomy, know what you're palpating. And oftentimes, especially in orthopedics, it hurts where you push. And
Exactly.
that use
Absolutely.
that usually tends to line up. And so I take a lot of time, as you said, looking at patients in resting positions, seeing if their hand is favoring one way or the other. In my head, I'm pushing on things, and in my head and even out loud, sometimes the patients would be like, what are you saying? I'm saying, oh, no tenderness over the radial styloid, no tenderness over Lister's tubercle, no
Yeah.
tenderness at the base of the first CMC. I'm just kind of saying it out loud as I'm palpating it, because if they are tender there, and the other thing I try to get across is go look back at the x-rays. If you take a quick look before you go in the room and they're negative, but you go in there and they have some palpable tenderness over an area, go look at the x-rays again before you discharge them, and you may see a subtle finding in that area that you didn't see initially, but then you have the benefit of the palpation in that clinical exam.
Yep, absolutely. And if you can pull up the x-rays in the room,
Yeah.
seeing is believing. So if a patient can see the x-rays and see what you're looking at and you're walking through, okay, this is normal. This is a sesamoid bone. Nope, that's not a bad thing. That's your hook of hamate. Like just normal findings that we see on the radiographs, walking through that and showing the other thing I talk about too with fractures, not specific to scaphoid, but usually metacarpals and phalanx, is that the outer lining, that cortex of the bone is like an eggshell. So if it's cracked, it's going to dent in, it's going to stick out. Typically, we look for some disruption of the cortex. And you're pointing out, I don't see anything on any of these bones. So walking through that out loud is a great, great idea.
Yeah, I feel like it just helps me to kind of make sure I'm palpating all the key anatomical landmarks. Plus, sometimes it gives that patient confidence that, hey, this person knows what they're talking about,
Right.
or they just think I'm talking to the voices in my head. I'm not sure which one, but
Yeah.
all right. Well, I appreciate your time. I'll let you go. Thank you very much. I think this was
Yeah. Thanks for having me.
educational. I'd love
Yeah.
to have you on again. As you said, I think you can talk for an hour just about distal radius fractures. So,
Right. Yep.
yeah. But yeah, I appreciate your time. Well, I hope everybody enjoyed this episode. I think this was a great episode regarding upper extremity injuries, kind of how to think about and or treat acute upper extremity injuries. Vanessa does a great job discussing this. Please go to her website, orthorefresh.com. Again, I think this is a fantastic resource if you're looking to update your knowledge on upper extremity injuries, and also for casting and splinting. She has a great PDF that goes over what cast and splint should be used for what specific injuries. Thank you again for listening. Please follow us on social media, both Facebook and Instagram, Ortho on the Go podcast. Also, stay tuned next week. Next week, I'm going to have Laura Rennie. Laura is a youth athletics coach. We're going to talk about the importance of youth athletics in our young population. And I think it's a great conversation. I really think you guys will get a lot out of it. So definitely tune in next week for this episode. Thanks again for listening. Have a good day.